Dr. Namrata Sharma for allowing us to be involved in this amazing meeting. So, the International Ophthalmic Conclave is a 3-day meeting with multiple rooms, and we, as the Eye and Contact Lens Association, are thrilled to be a part of it. So, I'm going to bring up my screen, and can everyone see my screen at this point? Okay, so let's get started. I'd like to share with you basically a very simple protocol that we use for successful outcomes. I've been at the University of Pittsburgh for quite some time, and we were lucky enough to recruit Dr. Vishal Janji to join us in our efforts, and it's been quite a fun ride. So we're going to share some information as we see all these patients with infectious keratitis. So here are my financial disclosures. Nothing is relevant. When faced with a patient like this, your heart kind of sinks because you know that there's a long course that's going to ensue. This patient has an obvious corneal ulcer, but if you look carefully, there's actually also a LASIK flap in this cornea. And this patient had had LASIK elsewhere, was waiting to have an enhancement, was simply wearing a contact lens for maybe about a -1 correction and developed this severe keratitis. So at this point, time is of the essence. And I'd like to share with you just some thoughts on how to manage these patients effectively. First of all, you have to think about, why does contact lens keratitis happen? Well, the chronic hypoxia leads to decreased corneal sensitivity. There's also a thinner corneal epithelium in contact lens wearer, which leads to less a barrier to bacterial penetration. There's also reduced shedding of the corneal epithelial cells, so they have increased binding of these bacteria to the cell surface. The reduced barrier function of the corneal epithelium can be seen after just 2 weeks of soft contact lens use. So it's rapid change in the cornea. And we know that in soft daily contact lens wearers, the incidence is about 1 in 2,500 contact lens wearers per year. But when they wear contact lenses overnight, that rate increases dramatically to 1 in 500. There's been no difference with newer contact lens materials or the introduction of daily disposable contact lenses. And the organisms that we see most commonly in the US is Pseudomonas, for sure, in terms of contact lens wear. There's also Staphylococcus species, strep species, and I'm going to speak about Acanthamoeba as well, because that has been quite an issue, and it's such a challenging organism to treat. And we did see some outbreaks with Fusarium as well. So the risk factors, by and large, overnight wear and poor hygiene. There's also issues with tap water exposure, contamination of the contact lens storage case, travel, swimming, overuse, misuse, and again, there were some outbreaks due to contact lens solutions that we had seen. So this first step when you face a patient who has a contact lens related keratitis is to ask a good history. And so we start with, what type of contact lens do you wear? And don't forget to ask if these are colored or cosmetic contacts, because that can make a difference. I ask, how many nights do you sleep in your contacts? Do you notice I don't say, do you wear them overnight? I just assume that everyone does, because most people do. And they don't like to admit it because they know it's sometimes problematic. So then we ask how you clean your contact lenses, which solution they use, do you top off the solution? And, and again, we ask, how often do you use tap water to rinse the lens? And how they clean the case, and do you shower in contact lenses? So we know tap water and contact lenses should never mix. So it's really important to ferret out if they are using contact lenses, and not to be threatening when you're asking, because patients want to tell you what you want to hear. So try to get to the truth and not be too threatening. So the second, The second issue
look up.
is to, oh, I don't
Look
want
down.
audio on this video. Hold on 1 second.
Look
Basically,
left and
the
right.
important thing is
Perfect,
to do a
Tell me when
careful
you're starting.
assessment
Yeah.
and really look all over the eye, because some people have retained contact lenses, and make sure you, I always like to do a very complete external eye exam, because even in acanthamoeba keratitis, there can be associated scleritis. So you really want to get an idea of the entire lay of the land, and whether floppy eyelid syndrome, et cetera, could be contributing, or whether someone has, giant fornix syndrome, for example. So another critical thing is when you face an eye that's covered with mucus and purulent material, you have to remove all that mucus and debris to really understand the depth of infection and to see how thin that cornea is. And then you decide about the need for culture. We find that there's really no need to culture small or peripheral corneal ulcers, but we do recommend cultures if they're large or extending to the mid or deep stroma. If they're central or vision threatening, we always culture. And if it's a post surgical patient, for example, a refractive surgery patient, we always culture. Now, if the picture I showed you of a LASIK infection had been where the infiltrate was more under the flap, then that patient you'd have to lift the flap and get material from under the flap in that case to really get a good sample. And remember to culture if there's poor response to the initial treatment. So we do the routine smears and cultures. Again, very important to think about all different types of organisms, including fungi, acanthamoeba, etc. And just a few tips on culturing. We like to take the material from the leading edge of the infiltrate because that's where the highest yield of organisms is. Don't be shy, get an adequate specimen. In fact, if you debulk the organism and debulk the infiltrate while you're removing the material, it's actually a good idea. Don't use cover slips on slide, and again, debride as much as possible. And we found that culturing the contact lens case, and contact lens solution can be very helpful in select cases. And then there's the education speech, the doom and gloom speech that we give our patient. We talk about the risk of vision loss, perforation, the need for corneal transplantation, and the importance of compliance cannot be stressed enough. Until we have Joe Cellino's drug-eluting contact lenses, we depend on drops. And so what we do is we actually give a patient, if we're not sure about whether they'd be able to do this, we give them a drop test, and we actually, have them apply a drop of anything, even artificial tears, into their eye just to see how they can handle it. And if they can't, then we think about admission to the hospital. So for smaller ulcers, and again, this is in the treatment step, we really rely on fluoroquinolone monotherapy. But when you do that, dosing and compliance are critical. And we like to use fourth generation fluoroquinolones, and we do a loading dose. So these are concentration dependent killers. We want to get a ton of that antimicrobial into the cornea as soon as possible. So we do every 5 minutes for 4 doses, every 15 minutes for 4 doses, and then every 30 minutes until 11 p.m. that night. And then we have them use it hourly around the clock. For larger or deeper ulcers, we employ the fortified antibiotics, so tobramycin plus cefazolin or vancomycin. And after the loading dose, we have patients use the drops hourly around the clock, and they just wait 5 minutes in between the drops. We don't think that waking a patient up every 30 minutes to do alternate dosing is necessary. And we also tell them you can keep the cooler near the bedside so you don't have to go to the fridge every hour. So then we have to think about which is the correct antibiotic. And if you're unclear, just remember this website, imicrobiology.upmc.com. If you remember nothing else from this lecture, please just take that pearl away. And everything that you need to know is in that website. This is our Campbell Lab website, and we're really happy to share the information that we have. We even have a link there to a course that we did at the Academy, and it basically has our Cliff Notes. And you can find information about lab testing, antibiotic susceptibility, antimicrobial therapy, our current research, and also photos that you're welcome to use in your talks. So, for example, you can look at antibiotic susceptibility of keratitis specimen from our lab. And if you had a strep pneumo infection, you could actually look at the susceptibility of the bacterial isolates from keratitis specimen that from our lab to common antibiotics. And so this is updated. This was last updated January 1, 2019. So you could see that, a good choice would be bacitracin, vancomycin. Either the quinolones work wonderfully, but of course we would stay away from gentamicin in this case. And then step 4 is to assess treatment efficacy. And the first thing I do when I walk in a room of a patient who has contact lens keratitis is I just say, do you feel better, the same, or worse? That answer to the question will basically determine whether I'm on the right path or not. If they feel better, and even if they don't look better, then I'm going to stay with my therapy, because often patients start feeling better before the clinical exam improves, especially in Pseudomonas ulcers. If there's no improvement in 48 hours, you really need to modify therapy. So check the microlab and remember to use the most potent cytal agent. We switch to cover MRSA in healthcare workers, then start thinking of atypical organisms if you're not getting improvement in 48 hours. And we would switch to fortified antibiotics if the patient was on fluoroquinolone monotherapy. We would also consider a confocal microscopy or corneal biopsy. And remember that not all agents have equal corneal penetration, and biofilm can be an issue. So intrastromal injections of antimicrobials can be very helpful. So let's just talk about a few cases. This is a patient who came in, and she's a 65-year-old woman who wore rigid contact lenses. And she was treated with this infection with antibiotics, steroids, antivirals for 3 months with no relief. So I said the question that I always ask, do you use tap water to clean your contact lenses? And she said, yes, of course. I followed the instructions on the bottle. I said, I don't believe you. There's no contact lens solution which would ever talk about tap water. I said, bring your bottle in the next time you come. So here is her contact lens solution bottle. I flipped it over and was horrified to see that it indeed said, rinse off thoroughly with fresh tap water. So this is obviously a problem. And it was time for some more investigation. So we actually conducted a survey of contact lens solutions, and we published this in the Eye and Contact Lens Journal. And it turns out that although none of the soft contact lens products recommend tap water, 84% of products related to rigid contact lenses recommended the use of tap water to either rinse surfactant off the contacts or the storage case. So again, problematic. So it was time for some advocacy. And this is where, I was so happy to be a member of the Eye and Contact Lens Association. We advocated for change and we were successful. So, the company that made the product, Bausch & Lomb, to their credit, talked to the FDA and submitted, and now they're going to change the labeling of the contact lens solution. In terms of treatment of Acanthamoeba keratitis, we know that it's challenging. You want to debride as much as you can, debulk. There's combination therapy with a guanide and a diamidine. And if it's not responding well, voriconazole can be helpful. So our patient, after 6 months of therapy, looks a bit better. She did go on to corneal transplantation. Here's another case I'd like to share, a 23-year-old with a red, painful eye. And here's her exam as she came in upon presentation. Now, you might first think, that looks like a dendrite. It's herpes simplex keratitis. But remember, HSV has the terminal bulbs, and it has a very characteristic appearance. This patient, our patient, had early Acanthamoeba keratitis. So we like to teach that a dendrite plus contact lens wear equals Acanthamoeba keratitis until proven otherwise. So any patient with epitheliopathy or dendritiform changes in the corneal epithelium, what we recommend is removing all of that involved epithelium and sending it to the microbiology lab. You're both doing something that is diagnostic and can be curative. Remember that amoeba start infecting the outer cornea and then spread deeper. And a ring infiltrate is a very late finding. So you can see that there's early acanthamoeba in the top slide, mid-stromal acanthamoeba in the middle, and then late with that very deep involvement on the bottom slide. And if we see ring infiltrates in acanthamoeba, we really missed the boat. It means that we missed the diagnosis or the patient did not come early enough for treatment. So we really need to not wait for this sign to diagnose acanthamoeba. And also remember that some acanthamoeba keratitis patients do not have pain. Unfortunately, they're treated for HSV keratitis for months at times and given steroids, which definitely makes things worse. Here's a really nice article from the BJO that talks about, what are the risk factors for bad outcomes with acanthamoeba keratitis. And the bad outcomes were associated with delayed diagnosis, corticosteroid use, a ring infiltrate, or older age. So again, please don't wait for that ring infiltrate. And we know it's difficult to eradicate because of the two forms, that active trophozoite and then the dormant cyst. Culture is important, but now we do PCR for acanthamoeba. And back to our patient, we did confirm the diagnosis of acanthamoeba. The patient was treated with a PHMB for 4 weeks only. And after some toxicity, the patient healed, vision recovered to 20/20, and the patient is actually wearing glasses full time now, is not interested in contact lenses. Let's just talk about one more case to wrap things up. So this patient is a 22-year-old female, and she came to our clinic with 4 days of worsening left eye pain and blurry vision. She actually had just delivered a baby and went into labor, fell asleep with the contact lenses, and then woke up with left eye pain. And, she had a habit of sleeping in her contact lenses for about a week at a time. So she started Visine and moxifloxacin, but was not improving. So again, here's my history. What type of contact lens do you wear? She's responded colored. Who prescribed them? Nobody. Where did you get them? Convenience store. Do you have glasses? No, I don't need them. Okay, so I was horrified that this patient, who's a new mother, developed a contact lens related ulcer from an illegally purchased colored contact lens that she got in the convenience store. So this is another kind of epidemic that we're facing because cosmetic contact lenses are so common now. 88% of women expressed interest in changing the appearance of their eyes with colored lenses, and they're very common in Asian countries. Majority are young female emmetropes, and the incidence of infection is challenging to estimate because there's non-traditional supply routes. But one study showed a 16.5-fold increased risk of infection for cosmetic contact lens wearers compared to regular refractive contact lens wearers. And another study showed that cosmetic contact lens wearers made up 12% of corneal infections presenting to 12 hospitals in France. And the risks are because the actual contact lens could be a problem. They're not made very well. The range of methods to achieve color is wide, and it can include chlorine, titanium, iron, unspecified pigments. And when there was a study that looked at the permanency of the pigment, and only 2 of 15 brands actually demonstrated permanency of that colored pigment when the contacts were gently rubbed with a moistened cotton swab. So the surface of these contacts are definitely rougher. And in addition to poor vision, there's definitely increased infection with higher levels of bacterial and acanthamoeba adherence. But here's the scariest thing that I read. Pathogenic organisms have been isolated in unused counterfeit contact lenses and contact lens solutions. And we actually examined this in our lab as well and did find bacterial organisms in some of the contact lens cases. So this is, again, the start of another epidemic. When another study looked at incorrect cosmetic contact lens usage among teens. 14% of pediatric patients had worn cosmetic contact lenses. Not surprisingly, 83% were female. 2/3 had not been instructed on proper lens care. Half of them, more than half, stored them in water and did not rinse them after removing. And 15% borrowed them from someone else. So it's scary and we need to act. So again, we are working through ECLA and through the University of Pittsburgh. We're working on education and advocacy. And Tim Steineman, another member, we're working with the FDA and the CDC to try to get to affect change. And we've contacted state and federal authorities regarding the illegal sale of cosmetic contacts. So here's a poster that we made where the patient wanted to look like this. And you can see the top picture. Instead, I look like this. Decorative contact lenses cause eye infections and blindness. So we're trying to get the word out on social media, actually, to really inform these young adults that cosmetic contact lenses can definitely be a problem. So I think my time is closing, so I'm just going to wrap things up. When to add steroids? I think the SCUT trial really has gone through this nicely, and I think we all know the importance of the SCUT trial. The key is that you don't want to use steroids in nocardia ulcers. That's the most important thing. And when you remember our patient, she ended up doing okay. She ended up looking okay and recovered significant vision. And she was pretty happy, did not have any LASIK enhancement at that point. So the pearls, proper management of contact lens related keratitis is important. We have to start with it: careful assessment, aggressive treatment, and remember to modify treatment if you're not seeing a response in 48 hours. Only use steroids in non-nocardia bacterial corneal ulcers. Educate our patients. Avoid high-risk behaviors such as tap water and overnight wear. And remember the website, imicrobiology.upmc.com. And thank you so much for your attention. We'd like to invite you all to Pittsburgh. We are building our UPMC Vision Institute, and it should open in 2022 in Pittsburgh. So thank you so much for your attention.
Thank you for that great talk.